Hi, I am doing the immune system. It is Module 6. The objectives, you should be able to describe the physiological process involved in the maintenance and restoration of health and wellness, describe the different types of immunity, and identify how stress and gender can affect the immune system. The next couple of pages are key terms, and you should have at least some understanding of them. Then we have the review of the immune response. The major histocompatibility complex in this distinguishes between self cells, which are also they contain human leukocyte antigens or HLA, and then there's foreign cells, which they also call non-self, and this does not have HLA. The organs that are involved with immune response, the primary lymphoid organs are the bone marrow and thymus gland. And the thymus gland serves as the reservoir for T lymphocytes. The function is the development of the immune system. Reduction in thymus activity and repeated infections can actually cause a premature aging of all phases of the immune system. Immunological aging due to thymectomy in infancy or childhood places the individual at risk for infections as an adult and possibly more susceptible to increased inflammation, more age-related chronic diseases, and autoimmune responses. Remember this. Immunological aging due to thymectomy in infancy or childhood places the individual at risk for infections as an adult and possibly more susceptible to increased inflammation, more age-related chronic diseases, and autoimmune responses. Then there's a secondary lymphoid tissue, and this involves the spleen, the lymph nodes, epithelial lymphoid tissues. The spleen acts as a filter. It collects antigen from the blood and then it destroys senescent RBCs. The spleen is mainly made up of tissue called red pulp. Throughout the red pulp, you can see lymphocytes that surround arterioles, forming pockets, which they call white pulp. And white pulp is responsible for generating immune responses to blood-borne immunogens and plays an important role in preventing septicemia. Removal of the spleen often results in life-threatening infections known as overwhelming post-splenectomy infections. And then you have the lymph nodes, which are responsible for generating immune responses to the immunogens in the lymph drainage and interstitial fluid that drains from local tissues into the lymph vessels. Epithelial lymphoid tissues, gut associated lymphoid tissues, so GALT, that's where it involves your tonsils, adenoids, Peyer's patches in small intestine and appendix. The GALT collects antigen from the surface of epithelial cells and digestive tract. This next is the overview of the immune response that we kind of talked about. Shows the bone marrow, the lymphoid cell, the thymus, the bone marrow. Talks about the T cell, the B cell, and then any cellular immunity and humoral immunity, and we'll talk about these more. Types of white blood cells or leukocytes produced by the body. Here's a diagram showing you the bone marrow stem cells go into myelocytic or lymphocytic, and then the lymphocytic has the natural killer cells, B cells, T cells, and they all break down. And then your myelocytic cells have your neutrophils, eosinophils, basophils, and then the monocytes, macrophages. Remember, deficiency in the neutrophils, which they talk about this, a patient becoming neutropenic or neutropenia, can lead to overwhelming bacterial infections. So The more decreased in neutrophils, the more you have a chance of having a bacterial infection. Then you have immunity, which is the normal physiological response to microorganisms and proteins, as well as conditions associated with an inadequate or excessive immune response. And you can look at this overview of immune system on YouTube. Innate immunity, which is natural immunity, is inherited within a species and it develops regardless of any type of an exposure, where an acquired immunity is an immunity that is not present at birth and develops either as a result of an exposure or through an external source, so like breast milk, the colostrum that you first get, or injection of immunoglobulin. There's acquired immunity, and you have two types. You have the humoral mediated immunity. It's mediated by B lymphocytes, plasma cells, and antibodies. And then you have the cell mediated immunity, which is mediated by T lymphocytes. Then we have active versus passive immunity. And active immunity results when exposure to a disease organism triggers the immune system to produce an antibody to that disease, where passive is provided when a person is given antibodies to a disease rather than producing them through their own immune system. So, immunization involves the stimulation of an adaptive immune system so that when exposed to the pathogen, their body has already developed immunity against it. Attenuated is using pathogen whose potency has been altered so it produces no or less severe disease. Oral polio is commonly used and it's a live vaccine. And then you have the dead pathogen, which is considered an inactive vaccine. So just active is when the immune system begins to produce the antibodies, and passive is when we're giving it. So that's where we're talking about immunizations. And then we have altered immunity. What is meant by it? Conditions in immune responses are either suppressed or they're exaggerated. Suppressed responses are referred to as either immunocompromised or immunodeficiency, and exaggerated responses are referred to as hypersensitive. So suppressed are immunocompromised or immunodeficiency, and exaggerated responses are referred to as hypersensitive. Suppressed immune response. There's primary immunodeficiency, which is a group of disorders caused by inherited or genetic defects in the cells and tissues of the immune system. And then we have the secondary immunodeficiency, and this occurs when the immune system is compromised due to an environmental factor. Example of these outside forces are like HIV, chemotherapy, severe burns, or malnutrition. They can be intentional or they can be adverse effect of treatment, so like the chemotherapy. There's exaggerated immune response. There's 4 types. Type 1 is anaphylactic, systemic, localized, anaphylaxis, hay fever, asthma, hives, food allergies, or eczema. Type 2 is cytotoxic, which is like your blood transfusion reactions or autoimmune hemolytic anemia. Type 3 is an immune complex, so like serum sickness, necrotizing fasciitis, glomerulonephritis, rheumatoid arthritis, or systemic lupus erythematosus. And the type 4 is cell mediated, so your contact dermatitis, tubercular lesions, graft rejection. Then there's hypersensitive reactions, so you have your localized and you have your systemic effects. Consequences of suppressed immune response, secondary to medications, 2 major types of problems that result from suppressed immune response, infection, and cancer. So, collaborative care for immunodeficiency, you want to monitor their immune function, watch their nutrition, prevent opportunistic infections, monitor and treat any opportunistic infections they get, and then drug therapy. And then we want to recognize when an individual has altered immunity. So, what we want to do is we want to look at their past medical history, family history, genetic history, any current medications they're on, any allergies to medications or any other substances, lifestyle behaviors, their occupation, their social environment. Then we have primary prevention. So you have immunizations, you want to avoid high risk behaviors, make sure adequate nutrition, exercise, infection control measures. Secondary prevention is used. Interventions that happen after an illness or serious risk factors already been diagnosed, and the goal is to halt or slow the progress of the disease if it's possible in its earliest stages. In the case of injury, goals include limiting long-term disability or just preventing re-injury in itself. Another thing you can do is screening, not specific screenings for general population, high-risk populations, and then screening for HIV for those that have a specific risk factor. And the secondary prevention is usually after the disease has occurred, but before the person notices that anything is really wrong. And then you have tertiary prevention, and the goals are to prevent further physical deterioration and maximize the quality of life. You want to prevent damage and pain from the disease, slow it down, prevent the disease from causing other problems, which we call complications, give better care to people with the disease, and make people with the disease healthy again and be able to do what they used to. Tertiary prevention targets the person who already has symptoms of the disease. Assessments of the immune system. You want to look at age and developmental considerations, immunizations and infections, allergies, autoimmune disorders, cancer, chronic illnesses, surgery, stress, and social support. Many diseases depend on the chronic states of inflammation for progression. So, atherosclerotic disease needs inflammation, whereas osteoarthritis generates chronic local inflammation. Chronic renal disease is associated with lower levels of erythropoietin and fewer numbers of all blood cells. Hyperglycemia is associated with increased infections primarily because of neuropathy and arterial insufficiency, which can cause decreased wound healing. COPD can cause recurrent infections due to increased secretions and decreased cilia elevator activity. For surgery, splenectomy, they become immunosuppressed, and OPI. Removal of lymph nodes affects immune function. Removal of thymus affects maturation and function of T lymphocytes. Organ transplantation. Most organs adhere on non-self by adaptive immune system. So you need to be put on immunosuppressive drugs for life, which puts the patient at risk for both acquired infections and opportunistic infections. And then read through this age-related changes in immunological function. So it goes through each system and it tells you what the change is and what the consequence is. And then we look at pharmacology, and these are medications that can cause immune suppression. So NSAID, corticosteroids, cytotoxic agents, and anesthetics can cause immune suppression. And then we want to do a physical exam, so physical signs associated with impaired immune function. So you want to do your vital signs. You want to include temp, blood pressure, respirations. Vital signs, you usually see an elevated temp, change in the blood pressure, pulse, and respirations. Constitutionally, you'll see chills, night sweats. Respiratory, you might see rhinitis, cough, adventitious lung sounds, so wheezing, crackles, bronchi, or bronchospasm. Cardiovascular, you might see dysrhythmia, vasculitis, decreased peripheral pulses, and anemia. GI, you might see hematomegaly, cirrhosis, splenomegaly, colitis, vitamin or vomiting and diarrhea. The GU system, frequency burning on urination, hematuria, proteinuria, discharge. Skin, you might see dermatitis, discharge, lesions, rashes, hematoma, edema, inflammation, and then neurosensory, you might see cognitive dysfunction, hearing loss, headaches, ataxia, tremor. So you want to assess the skin. You want to assess it for color, turgor, moisture, and temp. Skin changes are often the big indicators of an immune dysfunction. So elevated skin temp, you're going to see inflammation. Cool skin, you're going to think of it being arterial insufficiency. Different rashes also indicate immune status. This is one to remember. So your systemic lupus erythematosus, or SLE, you actually see a molar rash. It's a red rash in the shape of a butterfly that goes across the cheeks and the nose. So this one is a big that you'll see with people with SLE. And then patients with immunosuppression may also have thrush. And then a lot of times you'll have neurological dysfunction, which is really common in your HIV and AIDS patients. Your common diagnostic testing, primary, you're going to do red blood cell count, white blood cell count. You're going to do fluorescent anti-nuclear antibody, C-reactive protein, or SED rate. Other testing could be done as allergy testing, genetic, rheumatoid factors. You can do a Western blot test for HIV, torch antibody panel, or organ functions test. And then we get into the immunoglobulins, which are humoral mediated from B lymphocytes in the bone marrow. And this is in order of appearance. So you have the IgM. This is the first responder. It activates complement. It cannot cross the placenta, and it's the first Ig made by newborn. Then there's the IgA, which is the second most abundant. It's found in your tears, saliva, colostrum, bronchial secretions, GI, prostate, and vagina. IgG, this is the most abundant. It can cross the placenta. It activates complement and it binds to macrophages. Our IgD, this is required for maceration of B cells. And then the biggest thing to remember with IgE is this triggers the release of histamine and other mediators due to someone having an allergic reaction.